Good afternoon, everyone. I hope you're doing well this afternoon. Thank you so much for calling in to the VNAA Public Policy Town Hall meeting. This is our monthly call-in and check-in with membership to let them know what's going on here in Washington, D.C. and with federal policy and legislative updates. And then to also hear from you all what some of your concerns are and thoughts are. So to go ahead and get started, I'm going to go ahead and move on and review the agenda with you all. So today we have a variety of things that we're going to talk about. We're going to get a legislative update and talk about some recent bills that have started to be introduced. As you know, it's a new Congress, so we do have to introduce all of the various pieces of legislation that we were working on in the previous year. Just to remind you what some of our legislative priorities are, whether these are bills that existed in the former Congress or ideas that we're working with others on. We're going to do a bit of a policy update focusing on some executive orders and regulatory reform, speak to you briefly about the prior authorization coalition, touch on a CMS notice that went out to all the different MACs, and update you about pre-claim review actions. Then we're going to hear from Leah O'Rourke, who's one of the consultants that works very closely with VNAA and has for a number of years, to talk a little bit to you about Medicaid and what the different proposals kind of look like for those that we actually have seen the proposals, and what some of the rumors are about what some of the proposals might be. We're going to give you a brief update on what's going on around the Affordable Care Act and the replacement and repeal efforts that are going on, and then open it up to you all for questions and answers. So with that, I'm going to hand it over to Nathan Constable, who is our Director of Legislative Affairs, so that he can walk us through the legislative update. Nathan?
Thanks, Joy, and thank you, everyone, for joining the call today. Like Joy said, I'm going to give a quick update on recent introductions as well as our policy priorities, legislative priorities moving forward. As some of you may know, last week, Senators Collins from Maine and Senator Cardin introduced the Home Health Care Planning Improvement Act, S445. That's a bill that's been introduced for many Congresses now, and last Congress enjoyed very broad bipartisan support in both the House and the Senate, and we keep gaining momentum with each Congress, and our hope is that this year is the year that we can finally push it over the finish line. When Senator Collins introduced the bill last week, she gave a nice speech from the floor. We've linked to it from our Twitter account and our Facebook page, and if anybody's interested, I can send you the link. Or she does mention VNAA, but she really goes into why this bill is important and needed given today's current environment that we're in. We're getting closer to having a bill introduced in the House. I know they're a little preoccupied with ACA repeal right now, but we have identified a new Republican lead. As many of you know, Chairman Walden was the bill's lead sponsor on the Republican side going back the last couple of Congresses, but now that he's chairman of the Energy and Commerce Committee, chairs of the committees usually do not sponsor legislation. So we have worked with his office to identify a new lead, and we're hoping to have something introduced very soon. So keep your eyes out for updates from VNAA as well as your usual news sources. So moving on, just give a quick update about a few bills that are on our priority list and some happenings around those. And Joy might get into this a little bit more later on. The pre-claim review demonstration, which was instituted last year, it's set to roll out in April in Florida, and Senator Nelson and Senator Rubio authored a letter to CMS asking for them to halt with the rollout as well as try to create some sort of something better in its place. And 27 out of the 29 members of the Florida delegation signed on to that letter. It was something that we held up in many of our meetings that we held with Hill staff over the last month, and we'll see what happens with that. But it was a broad, it was bipartisan, and so we're still working and moving forward, trying to secure reintroduction of the PUSH Act, the Pre-Claims Undermined Seniors Health Act, which was introduced last year by Representatives McGovern and Representative and now Secretary Price. So we've definitely received some interest from new Republican offices on the Hill on getting this reintroduced. So it's really just trying to get that made a priority after all the ACA stuff dies down. The Palliative Care, Hospice, Education, and Training Act is another bill that has been introduced the last few Congresses, and last year it's received a Senate companion bill. So we've been working with coalition members and on our own on the Hill, bringing this to the attention of members. And last year I think it had over 236 co-sponsors. There's still interest on the Hill. It's looking like it will be introduced sometime this month. Representative Reed and Engel are back on the bill, are set to be on the bill on the House side. And Senator Baldwin is going to reintroduce on the Senate side with Senator Shelley Moore Capito as the Republican co-sponsor. So we're hoping that it'll be introduced sometime very soon. We'll be providing updates as that happens, and really working diligently with our other members in the community and the health community to really push this bill forward. I know a lot of people would like to see it passed in 2017. It's definitely a lofty goal, but I think it's something that we can achieve. It's cleared a lot of hurdles over the last few years. Had a hearing last Congress. Another bill or another item I wanted to mention is the Home Health Caucus briefing that we held at the beginning of last month. I think we might have talked about it a little bit last Congress, but we did receive great turnout from congressional offices as well as other key stakeholders, and we've been receiving questions, inquiries from staff about healthcare issues, and it was just a great turnout. And we look forward to working with the Home Health Caucus moving forward on other issues and just raising awareness about the benefits of home health as well as the innovations that are taking place that our lawmakers can learn from. And one other item is the face-to-face bill. I know we talked about it last previous months. It's definitely gaining speed. We've identified some potential people to take over the Republican mantle now that Chairman Walden had to hand over the reins. So we're hoping to get that bill introduced this Congress as well very soon after, like I said, all the ACA stuff dies down a little bit. So that is all that I have on the legislative front. I'd be glad to answer questions at the end, either type those in, or when it's time for a question and answer, feel free to ask, or you can follow up after with an email to me. I'd be glad to get back to you as soon as possible.
And just a note to play off of that, thank you so much for your update, Nathan. If folks could go ahead and use the chat function on their screen to go ahead and put comments and questions in. Heather will read those at the end, and we'll all answer those from there. But thank you again so much for your update, Nathan. I appreciate it.
Sorry. One thing I just wanted to add, I forgot to mention in the pre-claim update, Senator Nelson submitted a comment to the record, or submitted a question to the record for Seema Verma during her confirmation hearing regarding pre-claim update, and there was a pre-claim demonstration, and identifying the problems with it and either halting it, moratorium, or fixing it. She came back with, I'd be glad to work with your office on potential replacements for it, but it's something that it's another thing that we were able to do to raise awareness about the issue, and we're very thankful to Senator Nelson for his leadership, not only on the letter but also on the questions posed to Seema Verma.
Great, thank you so much for that, Nathan. Moving on from there, we were going to talk about some executive orders and regulatory reform. I know that we have shared with you previously that President Trump had mentioned his I call it the 2-for-1, for every piece of regulatory legislation that is passed and regs that are passed, he would like to see 2 for elimination. So following on that vein of work that he's been doing, he did sign another executive order on February 24th directing all agencies to appoint a task force to identify regulations to repeal or modify. In particular, the task force are to identify regulations that hinder job creation, are ineffective, or are costly. And these agency task force must present their list back to the White House within 90 days. There are 60 days for these task force to form at each of the different agencies, and we are targeting the one that will be going to HHS. VNAA has started a letter, and I will say the focus of our letter, we're just waiting to have, first of all, a regulatory officer, which is what they're calling them, that will be appointed to the agency, find out who that is. We will be reaching out to Price's office. Our key targets for this that make the most sense following under the guidelines of hinder job creation, are ineffective, and or costly would be the pre-claim review demonstration itself, and then also face-to-face. While we are pursuing legislative angles for both of these issues, at the same time we want to take advantage of all opportunities put in front of us, and we felt it was important to highlight these 2 issues to get those in front of the regulatory task force that will be put in place at HHS. We did hear from a few of you within the state associations of other concerns you had. We do continue to maintain a list of other regulatory relief that we would like to recommend. As you know, as I mentioned with President Trump's 2-for-1, we want to make sure that those that we know at HHS are well aware of our different concerns, but we feel like these are 2 of the largest hurdles that many are facing. Also, we're going off of the fact that, you know, when Secretary Price was Representative Price, he was very helpful with all the pre-claim review demonstration work, and we would like to see a continuation of that, and we feel like this is something that would be achievable with him. Obviously, he knows about the issue. His staff was extremely helpful. A member of his staff has gone over to HHS to continue her work with him, and we think that's great. We think that's a great way for us to continue the relationship, not just with Secretary Price, but with his staffer who knew us very well. So again, we are focusing heavily on both the elimination of the face-to-face requirement and immediately ending the pre-claim review demonstration. While the PUSH Act only calls for a pause, we are asking for just a full-out ending of both of these regulations. So I just wanted to put that before you. Also, something that we shared in member update as well, but we also just wanted to highlight it with you all. You know, earlier in the year, it was discussed at the end of January that there was a group that was focusing on prior authorization, largely the AHA and the AMA, and they had other groups that worked with them. They were looking at different barriers that are put in place when it comes to prior authorization and concerns that they had. So we have reached out with them, and we have joined this coalition and are now signing on to their principles around prior authorization. We know that many of you are very concerned. We do not want to see pre-claim review grow. And actually, just as an update to you all, we have reached out to United Healthcare, but because in every state but Texas, where they do managed care, they have eliminated the prior authorization requirement for home health care. They feel it is not necessary any longer. We have reached out to them, and they are going to provide us with the research and decision-making that they use, which I think will be extremely helpful for our advocacy efforts in this area. So I just wanted to highlight that with you all. If you did not see the MU article, I'm happy to share with you the link where you can see all of the different aspects of the Prior Authorization Coalition and some of their key concerns. Keep in mind, much of this work was created prior to us joining on, but we are looking for ways to better collaborate and help them and them help us, so vice versa. The other area that I wanted to bring to your attention, which seems kind of wonky, but it is a good move. CMS has halted the MACs from creating any new or revised local coverage determinations or local coverage articles until further notice. I know that many of you have had a great deal of issues with your MACs recently, and that many of you have appeals sitting with ALJ that goes back to some of these local coverage determinations and local coverage articles. I know that we were working with several of you on very specific issues and working with CMS, so we were gratified to see that CMS did go ahead and pause for all the A and B providers, just so they knew that the MACs are not to post any new or revised LCDs or LCAs. I think that this is an important first step. I do see it as a sign that CMS sees the level of misalignment between the various MACs and the decisions that they are making. I want to say thank you to a lot of our system members who have been great for us to be able to highlight some inconsistencies that they see within their own systems, and then those of you who have called in with specific concerns that we're able to highlight those with CMS. We do continue to reach out to them with various concerns that we have with the MACs, but just wanted to let you know of this movement. I do know that there have been specific areas where some new local coverage determinations have come out that, you know, just for instance, failed to recognize about negative pressure wound therapy, that there is such a thing and that it is effective. Our key concerns in this area is that they don't seem to be making these policies and decisions based on the clinical knowledge. It comes from more of a policy and insurance knowledge. So one of the key areas that we are pushing with CMS, and we will use Danielle Parati in our office to help carry through some of this message, is that there needs to be a better body of research and there needs to be actual clinical knowledge applied when they are creating these LCDs and LCAs. We think that that's extremely important when making these decisions, and something that is greatly missing from the current guidance that they've been using. So we just wanted to highlight that for you all, and we'll continue to keep you notified and abreast of all the different movement out there around this issue. Again, if you have a specific concern that arises with you all on these areas, or an issue you've been having with your Medicare administrative contractor, please reach out and let us know so that we're able to capture that and bring it directly to CMS's attention so that they can help push some of this along. Thank you again to those of you who have been reaching out. We have been following up. Unfortunately, I will say that, you know, there is just a lot of folks who are reaching out, and CMS is becoming greatly aware of all the issues going on. So that's actually a good thing. So the other thing I wanted to kind of raise for you all is kind of the pre-claim review actions and what's going on. As you know, there are, you know, much like other issues, we kind of take a legislative and a policy approach. You know, basically any road in to get us to the finish line. As Nathan mentioned, we continue to look for sponsors and work for the pre-claim review legislation that Congressman Price had introduced last year to look for a new original co-sponsor, a Republican lead for that. But at the same time, you know, I did mention that we are putting forth in the regulatory review officer letter that we would like to see pre-claim review eliminated through that. And then additionally, Senators Nelson and Rubio sent another letter that most of the Florida delegation signed on to. I believe it was 27 out of 29 members, which is great. Florida is the next state that is up for pre-claim review demonstration. They initially were able to achieve a pause the last time Senators Rubio and Nelson got together and sent a letter to CMS, which, let's be honest, that does not happen very often, that those two individuals work together on an issue that doesn't involve a hurricane or Zika. So we really appreciate their work on this area. They were able to achieve a pause. Florida was supposed to be implemented in October. Obviously, this is now April. But, you know, CMS is taking advantage of the lag in leadership and stated that it was going to go forward. So we definitely want to get this in front of Secretary Price for his review, and hopefully he too will either pause again or eliminate pre-claim review demonstration. I think it's important for us to continually highlight that this is a documentation issue that was largely caused by face-to-face, that this is something that where we cannot use the home health record to substantiate lack of detail on the part of the doctors, and at the same time we neither have a carrot nor stick to move the doctors to fully document the way the MACs would like to see. That in itself tends to be inconsistent when a non-clinician would like to see additional clinician verbiage on a form, when some of the things that snag up a claim is you just numbered 1 through 25 instead of saying 1 out of 25, 2 out of 25, that you used one of CMS's recommended forms that they have on their website, but the particular MAC doesn't like the form that you use. It's these sorts of small minutia that should not be causing claims to be held up or for them to be deemed an improper payment because of poor, in their mind, documentation or incomplete documentation. I do admit that there are times that there needs to be more information, but if a doctor writes because I said so for the reason of determination of the person is homebound or they were not as expressive as the MACs would like to see, we do need to figure out a way to eliminate that concern and that we are able to make sure that claims are paid appropriately and that these do not continue to be a blight on the record of home health care. I am very tired of seeing the 59% improper payment rate used as some level of judgment on the home health care agencies when prior to face-to-face being put into place, it was down in the teens. I'm not going to say all home health care is perfect or that we do things flawlessly. I just do not think that 59% of the work that is done by our member agencies is improper in any way. And I think that Dr. Agarwal, who used to be in charge of the Center for Program Integrity for Medicare, said it best when he said that this is not fraud, that this is poor or incomplete documentation. And I think that what we need to do is go after ways to fix that issue, which elimination of face-to-face or modification of face-to-face would in fact fix, rather than creating this excessive administrative burden that just takes far too much time and money to complete for each of our agencies. We had a notification from some of our members in Illinois that they are getting notices also from their MACs that they aren't getting full claims completed in time with their, they're slowing down their RAP form. And unfortunately, it's because they're resubmitting these pre-claim reviews over and over again to get to a conditional approval before they submit, so they don't take the minus 25% hit that if you do not do pre-claim review occurs. So all of that being said, just wanted to let you guys know where we are moving. Obviously we're moving legislatively, we're moving directly with policymakers. We really appreciate Senators Nelson and Rubio for getting out there in front once again and sending a letter to CMS and to HHS and Secretary Price, and that we are also continuing to look for other options for elimination. So that being said, I'm actually going to switch around the order. We're going to go to ACA repeal and replacement and then to LENA on Medicaid, because there are some aspects of ACA that that can be further clarified for information on Medicaid. So just more of an overview and just update for you all would be helpful first. Obviously, if you've watched any news or read the papers lately, you've heard a lot about the repeal and replacement of the Affordable Care Act. There is supposed to be a bill that will come tonight or tomorrow that will go to Energy and Commerce and Ways and Means. That will be the repeal and replacement legislation that's put forward. There is quite a road to get through in order for it to go forward, and I know that there is a lot of speculation about how quickly this can be done. It does need to go to Energy and Commerce and Ways and Means, policy committees, and then obviously budget and rules. There is quite a lot of work that has to be done before the bill would see action on the House floor and then need to go over to the Senate. in speaking with some of our policy folks today, you know, a good point was raised, and it's something I've seen happen before, where often what you'll see is you'll have one piece of legislation, but within an hour there's a manager's amendment where there's been deal making or conversations that have gone on and some flexibility that happened. Yes, they're absolutely talking about moving tax credit. There's a great deal of work going around Medicaid reform, whether these are block grants or per capita caps. And then the overall goal is to have this passed by the House before the Easter recess. While you know there is the overall expressed goal of it also going through the Senate before the Easter recess, I would say that that is overall less certain. We will continue to try and keep you all updated about what these different aspects look like. We did share with you previously what some of the different proposals around what a per capita cap or what a block grant would look like in your state, and shared that with you all in MU. It was a tool that Manat had created. If you want to go back and reference that again, that was in MU, but if you need it, just let me know. All of that being said, I think it would be helpful to kind of go through a brief overview of exactly how Medicaid works in your state, what these different reforms could mean or look like. And for that, I do want to hand it over to Lena O'Rourke. Lena?
Thanks, Joy. Can you hear me okay?
Yes, I can. Thanks.
Fantastic. And thank you all for your patience in my last-minute flipping of the agenda. I thought it would be helpful to put in context this Medicaid piece because it does end up being a big part of what's being discussed on the Hill. And the context here matters because there are two things going on with Medicaid. There is this Medicaid expansion that allowed states to expand who they offer Medicaid to and to get the regular federal money coming in for that. And then there's a second piece, which is sort of the Medicaid funding more broadly and the policy goals behind that. And these two are really blended and braided together, but represent different streams of work. Quickly on the expansion piece, this is the key part of this package that Joy was talking about that we expect to see this week. The proposals, while unformed or public yet, are likely to deal with how much federal funding is going to come into the states that have expanded Medicaid, and how they will either keep those expansions funded or will they phase them out over time. And also, you know, what type of additional funding may be available to states who did not expand Medicaid, and, you know, to keep them whole as well. So there's this expansion piece. Then there's this parallel track, and that's what Joy has asked me to spend just a minute talking about, which is the broader efforts of federal Medicaid reform, which is being done in the context of reducing total federal Medicaid spending and or to make federal Medicaid spending more predictable. And, you know, if this is being done in the context of a budget package or a reconciliation package, it's looking at setting spending targets and showing scorable savings on these targets. And that's important because a lot of the conversation involves how states want to reform Medicaid. But really this conversation about funding is being done through a budget lens and with the goal of reducing federal Medicaid funding. This is important for all of us to understand because under any circumstance, and I'll tick through them in just a second, but there are these block grants Joy mentioned, there are these federal per capita caps that Joy mentioned. All of that is on the federal spending, and so it's shifting costs down to the states to figure out how to deal with. And it's just important to understand that context as you evaluate what the House does, because we have to think kind of 3 steps down the road about how pulling federal money out of the state will impact your ability to serve people in the state, and what that means for payment rates and what that means for total Medicaid spending in the state. So just quickly, and I'm not going to spend a lot of time on this, although I love talking about this, so we can spend a lot more time if you have questions. The per capita caps, which is what a lot is focusing on right now, it's a structure under which the federal government sets a limit on how much it spends per enrollee. And so the current financing structure, what we have today, guarantees a percentage, a specific percentage per state of all qualified Medicaid spending for all enrollees. So for however much you spend in that enrollee, the federal government reimburses the state a certain percentage. This per capita cap, though, as the name implies, sets an upper limit on how much the federal government will pay, and it's a static limit. And that's set for a base year, and it's adjusted annually based on a federally determined growth rate. But it is capped, and it doesn't matter if the per enrollee spending for an individual is above that cap. That extra cost is borne by the state because the federal government's money is limited by whatever this cap rate is. It is different than a block grant. A block grant is a total capped grant to the state that is static without regards to the number of people who enroll or who need coverage. The per capita cap does adjust for enrollment, but under both, again, being done through this budgetary lens, these are limited federal support for Medicaid costs. And so how is this determined? What do we need to be looking for? And how will we all be evaluating these proposals as they come out? And in determining these, there are a couple of different levers that the federal government can use to set the per capita caps, to figure out what they're doing. And they can adjust them per beneficiary type, and most of the proposals do recommend separate base rates for the 4 major beneficiary types: seniors, people with disabilities, non-disabled adults, and children. And it would be a separate amount for each of these eligibility groups to allow a more appropriate payment for beneficiaries as opposed to a single national average, everyone in Medicaid gets X. This allows a little bit more flexibility for the type of beneficiaries and their relative attributes. It's possible to do state caps versus national caps, which allows more regional variability. It does matter what base year you use, as well as what the growth factor is. I'm not going to go into that very much. It gets into it's a little out of my wheelhouse and into a much bigger rate setting policy, but we can explore that more if you have more interest. I think what's going to be important, particularly for the populations we serve, is how the risk adjustment factors go, and how to appropriately set that per beneficiary spending rate, and what that underlying methodology is, and how it adjusts for patient characteristics. I think that's something we all have a lot of experience in, and what that means, particularly for vulnerable patients with a lot of chronic conditions. And we'll be evaluating these proposals as they come forward. I think the reality of this at the minute is we don't quite know what the proposal is going to look like. In the next 24, 48 hours, I think we should have more of an indication of the directions they're going. For both the expansion population and signaling more broadly in their Medicaid reform package. This is going to vary dramatically from state to state, and this is going to require a lot of analysis on what the various structures really mean for each state. But I think it's also important, again, as I said, to keep an eye down the road for what this could mean at the state level and as cost shifts to the states, and what that could mean for our ability to serve our members, or rather for our members' ability to serve their patients, and how this will impact payment rates, how it will impact access to care. I think there are more questions than it really answers. And so looking at each of these individual factors becomes really important as we're evaluating this body of work over the next couple of months. Joy, tell me, is there anything else major that I forgot to cover? Otherwise, I think I'm inclined to go to questions, and we can fill in any of the blanks.
I did want to mention, and I apologize if you alluded to it, and I'm reiterating something. I do think it's important to look at the speed at which these block grants or per capita caps will be able to adjust with the needs of the state. I know that there have been language that came out in the one the Republican offering that was more of just a bullet point list of what they hope to cover, that said that the current FMAP rate would be reflected in these block grants or per capita caps. It was up to the states to decide which version they wanted. And I just feel like it's important to note that often the states themselves are not being reimbursed at where their need is. At times there have been booms and busts that have been experienced by states, and their FMAP rate takes a while to catch up. It takes usually around 18 months to catch up with them if there's been a significant change, just because of the way that the data is collected and shared and produced and adjusted. And that, you know, that could be significantly meaningful if there were great economic forces that shifted or changed tremendously within a state. And I think something that others have brought up too is if you have a significantly senior population, or perhaps the opioid epidemic is truly costing your state a great deal of money, being able to prioritize is going to be very difficult with some of these capped amounts of pools of money. Does that make sense to you?
I think that's absolutely right. I mean, the beauty of the current financing structure is that it is countercyclical. It's a predictable share of funding, regardless of how many people come through the door, and it allows states to plan appropriately. You know, under a limited capped allotment, not only is there a lag time in responsiveness, it's the inflation factors just are not likely to be generous enough to keep up with medical costs. So I think there are a lot of ways the financing just lags behind where innovation and industry go, as well as looking at this pretty important and vulnerable population and their relative healthcare costs. So I think that, no, I think, Joy, you're absolutely right.
Thank you. And I do think absolutely that those are important considerations to take in. You know, I got to say, you definitely know when you're talking to DC policy wonks when we refer to the financing structure of Medicaid as beautiful. So I appreciate that. That being said, I do want to open it up to you all if there are anything that we brought up on our agenda today that you want to talk about, if there's anything else that you're experiencing at your program or within your state that you want to highlight for us, if you have additional concerns. If you don't want to share it either, you know, through the chat function so Heather can let us know, you can always reach out to me at jcameron@vnaa.org. So with that, I'm going to turn it to Heather to let us know if there's any questions for us.
Hi, Joy. Yes, we do have some questions. Let me go ahead and get them ready for you.
Great, thank you.
The first person was asking if there's a specific membership list of the members of Congress who are part of the Home Health Caucus.
There is a list, and I'd be happy to share it. Perhaps we could do a follow-up email to everyone. Some of the different tools I've mentioned, like the MNAT tool, et cetera. We could share that, and I'd be happy to include in that a link to the members of the Home Health Caucus as well to allow for that education and information. Do we have any others?
Thanks. Yeah. Is there any update on interpretive guidelines for the new COPs?
There is a whole day left. I did shoot an email to both Dr. Patrick Conway as well as Hillary Loeffler. Those are the folks that acknowledged that they received our letter asking for a status update. You know, obviously we gave them 30 days, which actually does extend until tomorrow, But since it was Monday, I felt, might as well reach out again just to get any guidance or information that they have about the interpretive guidance, and then to also push them on the fact that we had invited for them to do an overview webinar of the COPs to share with our membership. And then, from there, we're going to circle back with our board if there still is not movement. We'll circle up with the public policy board and then the board of directors itself and go from there. So thank you.
What about delaying implementation of the new COPs?
As we've stated, if again, and that is part of our overall strategy that I just touched on about, we did send out a letter to the CMS saying, look, if they could provide us with the interpretive guidance in the next 30 days, we felt that our membership would have a clear understanding, that the states would have a clear understanding, and the certifying bodies would have a clear understanding, et cetera. While we have reached out to you about specific areas that you have specific concerns about, so that we're able to ask for delays that with backed up reasoning, so that they aren't able to push it off easily. That it's a very weighted argument and persuasive. That is, our first step was to say, can you give us the interpretive guidance? So we are waiting for CMS's response on that. We also highlighted in our message to CMS on that we did not feel and cited why that the president's hold on regulations was in any way impacted. Interpretive guidance. Interpretive guidance is just that. It is not the creation or it's not the creation of new statutes or regulations. It's just interpretation. So, anything else, Heather?
Yes. One person commented that they had heard from a state association that legislation was being introduced to delay the COPs by 1 year. Have you heard anything about that? And if that is the case, is it something that VNAA would support?
We heard that on our state association call, and we have not seen the language. The state association that mentioned it to us was going to send us the language. They did not, and we reached back out to say, we still would really like to see the language, because we think, obviously, we want to read it before we make comments on it. So that's where we stand with that. We have not seen it at this time.
Can you provide some information on how the per capita caps will impact state with managed care organizations?
This is Lena. I think that's such the right question to be asking, and I don't think we entirely know. I think it's going to make it tough for states to negotiate with their managed care companies. I think, it's a similar but not identical structure, but I think the devil is in the details. I was actually trying to puzzle through some of this over the weekend, and it will work. I think it will work to make the contracting between the provider and the managed care company. I don't think it's going to do much to change that relationship. I think the relationships that will need to be examined is how the states pay and set rates with the managed care companies. It's a little hard for me to really figure it out until we see what the details of the proposal are. So, but because I think it's an extremely important question, once we've seen it, Joy, I'll follow behind with you, and once once we've had a chance to really reflect on what the language says and what it means, we'll answer that question more directly. I'm not deliberately trying to punt. It's just trying to figure it out in the absence of language is a little tough right now. But again, I think it makes for some complicated dynamics in terms of how states set rates with managed care companies, what that benefit package looks like. One thing I at least touched on but maybe needed to overly emphasize is with these caps are likely to come a loosening of what the benefit packages are and what is required to be covered. And what that minimum standard looks like will vary from state to state, which in turn means what those managed care contracts have to cover varies from state to state. So a complicated picture, and one with a lot of filling in that needs to happen. It is worth keeping a very close eye on, and I can commit to coming back to it soon to revisit with more specificity.
And I think that's the theme of the day. We absolutely need more information, so we're able to come back with more specificity. Thank you for committing to do that, because I do think that is especially important, depending on how things will shake down. I also think it's important to focus on and be aware of how your state might parse out any dollars and where they tend to focus spending the money, so that we are able to put forth the true quality and value of home health care when we're having those arguments. I think another consideration in this whole equation, too, is what will happen to any provider taxes that the state may have and agreements that they have around such in any of these different financing scenarios. Heather, do you have any more questions?
I do. Do you anticipate any relief from the OASIS burden?
I guess that would be through regulatory relief from the OASIS burden. You know, they keep updating and modifying OASIS. I don't see them doing a wholesale removal of OASIS, because we'd have to have some other method to report out all that information. It's especially important for a lot of our reporting functions, and as well as our functions where we do subcontract with a lot of these managed care entities. I have only seen it mentioned a few times, and that was by our folks, not by anyone on the Hill or within the administration for relief.
And that's all the questions that I'm seeing on this side now.
Okay, great. Thank you so much for doing that for us, Heather. With that, I will say, you know, we continue to reach out and follow up with you all with the information that we are able to share with you, that we're able to get, and try and give you guidance about what the impact will be to the industry on these different regulations and different policy changes and legislative changes. You know, tomorrow we'll put out a member update. We're hoping that we'll be able to link to you the legislation that either comes out tonight or tomorrow morning about the proposal for the ACA repeal and replacement, just so that you have that in front of you and you are aware of what's going on. Likely we would have to do a midweek release, because, you know, with them not having made anything public, it's going to need another a level of analysis done. But we do want to make sure that we're able to get and forward you the information as quickly as possible, so you're able to make plans and consider it when you're planning some of your business decisions going forward. So with that, I do want to thank you all for taking the time for calling in today. Again, my email is jcameron@vnaa.org. If you have any other questions or concerns you want to raise with me, I'm happy to schedule time to either have a conversation or respond to your email. I do want to thank both Nathan and Lena for calling in today and adding to our conversation. I think the information they provided was extremely helpful. And thank you all very much for taking the time to call in today as well. And thanks again to Heather for collecting the questions and running the show, basically. So thank you all. I'm going to turn back the rest of your afternoon to you, and appreciate you for calling in.